Good morning, everyone. I'd like to welcome you all to Grand Rounds. For those of you in person and virtually, it's delighted to have you all here. Before we begin, I'd like to extend our gratitude to our sponsors, Edwards Life Sciences and New Amsterdam Pharmaceuticals. So it's a real pleasure to introduce our speaker for this morning's presentation. The presentation is Novel Strategies for Managing Acute Decompensated Heart Failure by Dr. David Miranda. Dr. Miranda's journey in medicine began in Costa Rica. He completed his residency at Hennepin County Medical Center and fellowship in general cardiology at MHI, followed by a heart failure fellowship at Houston Methodist. He's currently an advanced heart failure cardiologist at MHI here. His expertise includes advanced heart failure, transplant. His expertise and interests include pushing the envelope in terms of thinking about new ways to manage acute and chronic heart failure. Dr. Miranda's dedication and excellence have been recognized throughout his career, including awards for clinical excellence as a resident, a general cardiology fellow, and as advanced heart failure fellow. Before coming to MHI, David served as the director of heart failure and medical director of the CCU at Centricare in St. Cloud. He's a national leader in the remote monitoring of heart failure as a director of a trial eligibility committee and one of the lead enrollers for Proactive. I'd like to have you all please join me in warmly welcoming Dr. David Miranda.
Thank you, Mosley, for that introduction. Everybody can hear me okay? So first of all, I want to say thanks to MHI to allowing me to present today. And as Dr. Bennett alluded, I'm going to talk about managing heart failure and what novel strategies that we have. So I don't have any financial disclosures. I want to mention that I'm the site PI for 2 of the devices that we're going to talk about, Venous HF and FACC trial. So the 3 main objectives that I want today is understanding diuresis in overall decongestion of therapy. And we're going to divide that in removers, dilators, pushers, and pullers. Number 2, diuretic resistance in how we evaluate response to therapy, tailored specifically on what we're doing here at MHI with our urinary sodium algorithm. And finally, number 3 is the technological advancements on people that we cannot diurese from a cardiology perspective. So a little bit of the background. The primary management of decongestion in patients that are hospitalized with heart failure, we don't do a really good job. 20%, we know that they don't lose weight when we send them home. And then 50%, they have some degree of congestions when they go home. The reasons for this might be because we don't have a way to guide therapy, the decongestion or diuresis. We don't do a good job with initial dose, and we don't do a good job on up titration. And then we don't know, or we lack some identification of diuretic resistance. Always, we are fear of the renal function as well. So we know that heart failure is a spectrum, and in this spectrum, we think about advanced heart failure as patients in the CCU on mechanical devices, ECMO, awaiting transplant, or LVAD. But today I'm going to talk about the bread and butter heart failure patient gets admitted in the telemetry unit, ACC-HA class C, functional 1, 2, or even 3. But this is what we're going to focus on. We know that heart failure is very common. We know that 1/3 of the patients will be rehospitalized between 2 to 3 months. And 2/3 of those patients will be rehospitalized or death within a year. The journey of heart failure, we know that every encounter that we have with those patients, it's a good moment to optimize GDMT to see if they have any inclusion criteria of CRTD, CRTP, or new devices. But those are more towards outpatient management. So let's get to the therapy or the strategies that we have for heart failure. And we're going to start with removers or diuretics. So let's start with a case. So we have a patient admitted to telemetry unit, 65-year-old woman, decompensated heart failure. In clinical exam, there's clear evidence of elevated JBP, lower extremity edema, a lot of congestion on X-ray, and moderate to severe MR. So vitals, the blood pressure is 103/76 with a mean of 85, heart rate of 94. She's breathing okay, but 89% on room air. The kidney function, we see that it dropped from 62 in clinic to 35 of a GFR. Sodium and chloride at a little bit low, and potassium is normal. So she gets admitted to the telemetry unit. We get 40 milligrams of IV furosemide, and what's the response? So after 2.5 hours, only 160 of urine output with a urinary sodium of 62. So this is very common. This is what we encounter. And I just want to walk you guys through why I think that there are multiple areas that we can tackle in this patient specifically, and why she might have diuretic resistance. So first of all, when we look at patients with heart failure, we need to understand that volume is not the same as cardiac filling pressures. So in this study in the ICU, they assess CVP on the axis, that is invasive filling pressures against overall total volume. So the main thing here is that there's little correlation between filling pressures and overall blood volume or overall blood volume in these patients. Even more represented here, when they had patients with heart failure and they divided in tertiles of fluid loss. So they all lost CVP. So the CVP dropped in all the patients. However, the fluid loss was different in all patients. So both cardiac filling pressures and volume status and overall total volume are important targets, but diuretics are treatment for congestion and not for filling pressures. So that's the main thing. So how do we assess this? So there's this toolkit that when we assess these patients, I always tell people to think about fluid overload and cardiac filling pressures. So right here, if I rupture my mitral valve right now, I'm in a euvolemic state. So if I rupture my mitral valve right now, my filling pressures will be high. However, my overall total volume will be normal. So that is the one in red. So in that case, like examples are acute valvular pathology, ischemia, hypertensive crisis or urgencies. Those patients have high cardiac filling pressures, but the etiology and the management is very different because we need to assess or treat the mitral valve, the ischemia, et cetera. Our patient, for example, had evidence of fluid overload with high cardiac filling pressures, so she needs rapid diuresis because that will help on both. So my recommendation is for loop diuretic, IV therapy. Think about the dose of the diuretic based on the renal function of the patient, and think about the frequency of the diuretic based on the signs of volume overload. Number two is optimize kidney perfusion. We always joke that the heart is the most important organ, and this might be our argument because the kidney can only diurese or excrete what the output is. So in this elegant study, they showed that the pulse pressure correlates really well with the stroke volume. So if you guys remember, the pulse pressure in our patient was a little bit narrow. So the first thing was to optimize the kidney perfusion, because if we don't have good kidney perfusion, the kidney will not be able to excrete. So the first one there in advanced heart failure, those are the patients with low pulse pressure and low diastolic blood pressure. So those ones, they need advanced heart failure therapies, they might be in shock. Our patient, for example, was in a state of exaggerated constriction. And think about the MR as well. If we add, thinking that the blood pressure is a little bit marginal, if we add more vasoconstrictors, we're gonna get worse MR, worse forward flow. So in this case, the best scenario was to some afterload reduction. So optimizing kidney perfusion. Number 3, give IV diuretics. So IV diuretics, and I see a lot of this in notes, that this patient has some CKD, so we're going to do gentle diuresis. I think that's totally wrong. I think we need to hit them hard, and the reason is because diuretics are very protein bound, and they need to get to the loop of Henle to act. So if we, in all that process is dependent on the renal function. So if we're going to give diuretics IV in an appropriate dose. Then Lasix, remember that comes from last 6 hours. So if we don't dose frequent, we're going to get a period in red of anti-natriuresis, and we're going to retain more sodium. In those patients will be more congested on discharge. So diuretic resistance, this is a very busy chart. The only 4 things that I want you guys to focus are on how the 4 areas that we can target diuretic resistance: venous congestion, increased proximal tubal reabsorption, hypochloremia. Chloride is the new diuretic. The new electrolyte that people are talking, and then the compensatory distal reabsorption. That is a mechanism of patients that are on high doses of diuretics at home that have compensatory sodium reabsorption. So the ADVERT trial, this is a trial that people think that is a trial published in 2022 at the New England. People think this trial is more of a trial to treat diuretic resistance. However, it's to prevent. Okay, so basically, what they did is they got all patients admitted with decompensated heart failure, and they just gave them acetazolamide IV, 500 milligrams from the beginning, and they were able to prove that there was decongestion within 3 days of the randomization. People went home feeling better, or at least less decongested, and they had more diuresis and natriuresis. So important to note that this is prevention of diuretic resistance. Number needed to treat of 8.5 to prevent diuretic resistance. Also chloride, this is a sub-study of ADVERT, where in the center there we have a patient in blue that got was diuresed but got placebo. So we see that the chloride drops. However, in red, the patient got acetazolamide and there was no drop in chloride. So the point is that the kidney, when it sees hypochloremia, it activates the renin-angiotensin system and creates more retention of sodium, increases the whole system that we are trying to block with GDMT. So these patients with chloride tend to have more diuretic resistance, less natriuresis, and more bad outcomes with high, like a more inflammatory state. And number 4 is assessing the diuretic response. So I mentioned on how to differentiate between filling pressures and total volume. We optimize the kidney perfusion already. And number 3, we prevent diuretic resistance. So now, how do we know that we're doing a good job if there's no biomarker or any way to follow? So this is where the diuretic response has come to show us how. So the way is with measuring the sodium in urine and to see if we get good goals. So in the left there, I have parameters that I just want to make clear that there's not a good cutoff. These have been, like, the Europeans have a different cutoff. In Vanderbilt, they have a different cutoff. Here, we're trying to be a little bit more lenient, because we know that low urinary sodium, less than 55, there's severe diuretic resistance, bad outcomes. At 80, but the guidelines have been between 60 and 80, there's diuretic resistance, and we need to do something to change therapy. And then I see this in the ICU all the time. When there's more than 100, they pee really good and they get decongested. So in the last 4 years, we've been doing decongestion in this way. So we have a patient with acute heart failure, and what we do is we decongest these patients based on fluid-based parameters like urinary output, weight loss, that are not the same on every person. And they don't give us any prognostic information. So the proposed mechanism is more to the left there. So basically, if we get to the urinary sodium threshold, we know that we are getting effective decongestion and the outcome is good. If not, we know that there is not a good response. We know those patients are at worst of bad outcomes, higher mortality, and that's a proposed. So if there's something to remember from this talk, is this slide. So why natriuresis and not diuresis? Because it's pragmatic, it's easy to measure, and it's based on personalized dosing and cheap. It's physiologic because it assesses the response to that diuretic, and it's the best indicator of the quality of the urine. And finally, it's prognostic because it correlates much better than diuresis on hard endpoints or weight loss. So is there any evidence on that? Well, there's 3 trials that I want to talk today briefly, and then there's an ongoing trial. So the first one is ENACT heart failure. This is a big study, 29 institutions, 18 countries, every single continent in the world. So basically, they told all the centers, you do your standard of care. There is this protocol for diuresis. Let's try it. So on the protocol, there was more natriuresis. That was the primary endpoint, so not a hard endpoint. But at day 1, they saw that there was more natriuresis and more diuresis on that. So very soft endpoint of natriuresis, but very, very interesting what we see here. So in all the subgroups, both male, female, baseline congestion or how they felt, EF, it was better, the protocol. So the urinary, but the most interesting thing that caught attention is the hardest patients with low GFR, elevated creatinine, CKD, or the patients that were at a higher dose of diuretic at home, PO, like the PTA dose was higher. Those is where the protocol worked the best. So those are the hardest patients, and the ones that receive the lower dose on admission and the escalation of diuretics is very poor. The length of stay was better with the protocol, but the most important thing, or the biggest takeaway, is patients with CKD and high doses of diuretics at home. That's where the protocol works the best. PUSH-HF, this is a small trial, one institution only. They randomized 150 patients to titration of furosemide based on the protocol, or 160 patients standard of care. They saw also more natriuresis, more urinary output as well. But the main goal of this trial was to prove that even at higher doses of diuretics in the center there was no worsening in renal function or autotoxicity with high doses of diuretics, et cetera. So pretty trial. So this is a pragmatic trial. It was reflective of clinical practice because there were older patients with a lot of comorbidities. EF was around 50%. So this is what we encounter in our daily clinical practice. The natriuresis guided was irrespective of GFR. So the natriuresis and not the worsening renal function was associated with better outcomes. They saw a drop in GFR, but there was no increased adverse events. So important that permissive, and they actually came up with a little phrase, permissive hypercreatinemia. So everybody can chill, renal function is gonna get worse, we're diuresing these people. Unfortunately, there's no overall effect on hospitalizations or mortality. And again, they showed that the people that are harder to diurese, they did better. This is a trial that is very small, only 60 patients, but it's very interesting because it was a protocol guided by nurses. So they give the nurses that point of care, and we actually give the nurses heparin, that is, I think, a more dangerous medication, and they titrate the heparin based on a protocol. So that's what they did. They just told them, here's the point of care. If the urinary sodium is less than this, just give another higher dose. And not driven by clinicians, it's all nurses. So they saw that it was safe with protocol. They were with the protocol of urinary sodium guided by nurses. They saw that there were more decongestion and less the length of stay was less. But that was the whole point, very small out of Belgium. And then the ongoing NIH Escalate trial. So this is out of Vanderbilt with Dr. Cox and Dr. Stevenson. It's a little bit more complex and it's really hard to understand. So basically, they get an IV diuretic in both arms. You measure the urinary sodium. The difference with the intervention arm up here is that they have a formula based on GFR, based on urinary sodium, in the creatinine, and then they ask the clinician, well, do you think that your patient is 80% congested, 60% congested, and based on that, they give the next dose. So it's a little bit more complex, ongoing, enrolling out until 2026, but very interesting to see their outcome. So back to our case. Our patient had low pulse pressure with a preserved diastolic blood pressure. So as we mentioned, we think that there was low cardiac output with a lot of vasoconstriction, making the MR worse. So if we give vasoconstrictors, everything's gonna get worse, more backward flow, more pulmonary edema. So what we did, we paused the beta blocker. We started IV nitroprusside for afterload reduction. In the table that we saw in the toolkit, high film pressures with clear volume overload. So we needed to do rapid diuresis. So we give loop diuretic every 6 to 8 hours. IV diuresis, as I explained, because of the CKD, the transient AKI that the patient was suffering, upfront acetylcholamide to prevent diuretic resistance. And then number 4, assessing spot urinary sodium and making sure that we have a good response to the diuretic, because we are individualizing the diuresis and making sure that that is the dose that that patient is responding to. But not everything works in clinical practice like you present in grand rounds. So what options do we have? And this is the third point that I want to talk about that we have here at MHI. So the technological advancements, and we're going to concentrate now on the pullers and pushers in the bottom. So these are device-based therapies that basically, depending on if you're in the venous system in blue, they act upon the venous congestion. So that's what we call pullers. And then in red, they're in the arterial system. In what we call them pushers. And there's also interstitial overload or tackling the lymphatic system. And we had a really good talk last fall about interstitium specifically last fall here. So these are ongoing trials, and we need to obviously make sure that these are good therapies, they're safe, and that they work. So I'm gonna talk 2 that we don't have here at MHI, and they're ongoing clinical trials. So the diuretic catheter is the first one. It's a catheter that goes through the renal, the femoral vein down to the IVC, and basically occludes the IVC intermittently, and the people saw a decrease in CVP, increase in urinary output. Obviously, these are patients in the ICU, bed-bound for at least 24 hours. The procyon, so this is an aortic device, so big sheath in the aorta, also bed-bound. They need heparin, and basically they're pushing into the renal arteries, the blood, and they produce more urinary output, less, they saw good outcomes. The trial is ongoing. They have the pivotal trial right now, enrolling. The main site is Detroit for this one. So now, what do we have here at MHI? So the precardial device, this is a balloon mounted device in swan gans. So we put it in the cath lab from the jugular vein. So it's like a swan gans that goes into the right atrium, right ventricle, pulmonary artery, and it has in a wedge position. But as you can see here, there is a balloon occluding the SVC, and we put it to the console, and in the console we can monitor at the ATMs, occlusion, deflation time, and we can see the line separating when the balloon is inflated here. So basically, there's a gradient between the venous system and the right atrium. In the whole goal or the thought is that we have we have we're able to decongest the kidney. So I started this trial when I was in St. Cloud, brought it here. It finished already the early feasibility study in the fall, and I'm going to give you guys a timeline. But this is the trial that we've been conducting here. So the early feasibility study was presented at THT earlier in this winter. So the primary endpoint was freedom from device. So it was just safe. So yes, it was safe. So what they saw in secondary endpoints, there was a decrease in right atrial pressure by 34%, decrease in pulmonary wedge pressure by 27%. Important that there was no change in MAP or cardiac index. That was a concern with the thoracic catheter that I talked to you guys from the groin, because the cardiac output dropped so much. This didn't change that. And there was a 130% increase in urinary output with no worsening renal function. And then the comparison, the diuretic was the same. So very promising. So how does it work? So the theory behind on how it works is that when the balloon is deflated, we have a big RB full of fluid. When the balloon is inflated, we decrease the size of the RB, allowing for some biventricular interdependence. So the LV gets bigger, more stroke volume, and also because of the gradient, we have a drop in the CVP, so we create a cardiorenal unloading. So this is an afterload of the kidney, a mechanical afterload of the kidney. So Dr. Naveen Kapoor showed here that at the time of the balloon inflation with the pressure volume curve, there's a significant reduction in left ventricular end diastolic pressure, and then there's more difference. So the stroke volume is bigger, and then no changes in blood pressure. So another investigator, Dr. Jacob Abraham, showed that there's more urinary sodium. Interesting, with the support, but also 24 hours after the device was removed, there was more natriuresis. So interesting results here. So this is the protocol that we have. So basically, patients get admitted to the hospital. We allow 36 hours of clinicians find a good dose. If they don't, the main inclusion is that they don't make more than 1,000 of urinary output in 8 hours. So if they meet that criteria, we screen them, we implant the device. The device has to, we have to do a right heart cath and make sure that they don't have RB dysfunction. And that was one of the experiences that we have, that there was some severe RB dysfunction. So even though the patient qualified from a diuretic standpoint, we were not able to enroll that. Then we leave the device for 24 hours. I'm happy to report that we did one case here, and we were the second institution to do it outside the ICU. This patient was in 4,000 with the catheter because they don't need an ICU. They just have a device, and 4,000 has been able to accommodate that for us. During that 24-hour period of time, we are not allowed to touch diuretics, and then take out the device, and then obviously there's no diuretic restrictions after that. So this is the timeline that the study has given us. So we are here. We enroll 60 patients for the EFS. So right now it's under review by the FDA. And then in Q3 with the Generation 3, we're going to start the trial, the clinical trial more for clinical outcomes. So we're selected among very good institutions, and starting the trial with Gen 3. So finally, the reprieve decongestion management. So this is a machine that basically sits at the bedside, and it's an intelligent diuretic giver. That's what it is. So basically, we connect the device, and then it analyzes the urine. So there's phase one of the machine, and it's a finding phase. So basically, it upregulates or gives very high doses or rapid escalation of diuretics to the patient until it gets to a urinary output of 525 mLs per hour, or gets to 200 milligrams of furosemide IV. Once it gets to that target, it calculates 50% of that IV furosemide as a drip. So for example, if we got to 200 milligrams of furosemide, that would be 10 milligrams an hour, because that's 50% of the whole day. And then the interesting thing about this device is that we have a background of normal saline infusion. So basically, it gives the patient half of the dose of the diuretic in normal saline to prevent the chloride and the diuretic resistance. So that's what it's doing. And then basically, if the urine output drops, then there's another phase of escalation of or finding phase. So basically, we set it up, dose finding, then we find a continuous infusion, then we see rapid upregulation of urinary output with a stable dose of diuretic. And then obviously it's managed by clinicians, so when we find that there's eubulimia, we stop and then we transition to oral diuretics. This machine, the algorithm is also driven by urinary sodium, but the machine doesn't analyze the urinary sodium alone. You have to enter it manually. So very interesting concept. So this is how it works. So in blue, we have the urinary output. Red is when we give the diuretics, and then the baseline normal saline replacement. So there is no bracking phenomenon by the kidney, and there's no antinatriuresis or hypochloremia. So they presented their clinical trials at THT in Boston as well. With standard of care, there was less diuretic, and we see that the furosemide dose was not titrated appropriately with the reprieve system. A lot of Lasix, and they completed. So the IV diuresis completed in 72 hours was faster with the reprieve system. More natriuresis, obviously, than standard of care. And then what they showed is that overall more sodium excretion, urine output was higher, more weight loss. And now the kidneys, back to the kidneys. In blue, with the reprieve, there was less change in serum creatinine, and the creatinine increased more than 0.3, that is the definition of AKI was less. And there was a trend towards less mortality and less rehospitalizations in red with the reprieve system. Obviously not big enough. This was also a safety trial, so we cannot have any hard outcome data from here. So putting these results in contemporary diuretic trials, for example, so look at the weight loss with landmark trials in heart failure like DOSE, chlorotic, PUSH-HF. So a lot of weight loss and way less renal function. So less renal function, less worsening renal function, I'm sorry, and more weight loss with this device. So finally, we have a urinary sodium guided diuresis work group, as I would call it. That when I started here, I proposed that to Dr. Bradley, and he has been helping me with HDI and same with Dr. Love Patel from the hospitalists. So we identified three hospitalists to help launch this. Same with Emily and Lisa Smith from the Advanced Heart Failure team to try to protocolize this and have it wide and bring it to the telemetry units. Our first experience with the Advanced Heart Failure team, what we noticed is that we need more numbers. They don't usually get the bread and butter heart failure patients that will benefit from this. When they get to this, guys, it's already a little bit late. So this is the protocol that Emily created, and that we're gonna have it hopefully everywhere, and to help guide this diuresis. And obviously it's too small here, but happy to share with everyone. So my takeaways or conclusions: understanding removers, dilators, pushers, and pullers, understanding the physiology of heart failure and how we diurese, the 4 points that I gave you guys on diuretic resistance, and evaluating the response to therapy, the sodium algorithm that we're using, and obviously reach out and let us know if there's nobody responding here at MHI. We have good technological advancements on these people that are not responding, and that we can provide some help. So that's it, and thank you so much for being here.
David, thanks for the great talk. I'll start with a question. So in the past, there's been a lot of focus on, for diuresis, the dose and the frequency, and protocols about escalating diuretic doses. Do you think a lot of those trials have missed the focus and the mark by not focusing on urine sodium?
Yeah.
And does the intermittent dosing versus continuous dosing of a diuretic make a big difference?
Yeah, so overall, very good, yeah. I don't think that intermittent versus continuous infusion make any difference at all. If anything, we know that the continuous infusion activates neurohormonal system more, and it's worse. But there's actually a good editorial on this specific question, and the answer is that every single heart failure trial, the outcome or the endpoint has been different. Some of them have been weight loss, some of them have been dyspnea and exertion. They're very subjective. So there hasn't been an objective parameter that puts them all together. There's always urinary output, weight loss, decongestion that are very subjective. But yes, I think that is part of the reason why those trials have been negative, because there's no objective biomarker to have that. So yeah, very good point. Yeah.
Thank you, David. It was a great talk. You've made me care about chloride again, the electrolyte I've been ignoring for the last 20 years. A related topic I wanted to get your take on is there was at least one presentation at ACC of a trial of fluid restriction.
Yeah.
And so you've talked a lot about the role of diuretics, and as you know, it's somewhat controversial, and there's maybe some evolving data that fluid restriction may not be as effective as we all like to think it is. Do you have any comments on the role of fluid restriction in these patients?
Yeah, so yeah, absolutely no fluid restriction. I think that fluid restriction it's bad. We're diuresing aggressively these patients. They get thirsty, and that thirst is just neurohormonal activation, and we should not do that. Actually, talking to some of the guys that have, Dr. Mullins, for example, that is like authority on the urine and sodium guided diuresis, they don't have any fluid restriction. They let them drink whatever they want. So I think that it's an error, it's a problem. If anything, this reprieve machine is giving fluid to the patient. So obviously not at a high dose, and if they're very congested and we have a patient that is drinking a lot, but I think our fluid restriction, if anything, is doing more harm. That's my comment.
Great talk. Should everybody who has congestive heart failure be treated with acetazolamide? And if that's the case, how often and at what dose?
So 500, just one time, IV if possible, and then before you start the diuretics. So if every single patient should be given, I don't think we know that yet. But if you see any evidence of some low chloride, or that they have diuretic resistance, yes. But we don't know that. Yeah.
Oh, thank you so much, Dr. Miranda. Very nice talk. The last one, with infusion of normal saline, I wonder have you guys come across with SIADH patients where the sodium could get worse with normal saline infusion at all?
So this is a clinical trial, and right now, obviously, the inclusion and exclusion criteria of these trials is very strict. So I'm sure we're not going to put somebody on SIADH, but yeah, probably not a good idea. But this is just a clinical trial, so probably no one with those conditions would be there.
All right, Dr. Miranda, thank you very much for your time this morning. We do have two virtual questions in the Q&A pod. The first comes from Dr. Renowitz. It's essentially piggybacking off of Dr. Heckman's point. but she's also adding in sodium restriction. So her words are, it's time to get rid of fluid restriction and sodium restriction. Eager to hear your thoughts and great presentation.
Thank you. So yeah, as mentioned before, I think that the people are moving away from fluid restriction. It's something that is very ingrained, especially like Dr. Bradley told me, change is hard. You're gonna have a tough time to do all these changes. But yes, I think when you talk to nurses and you tell them not to do fluid restriction, it's really hard. So I think I agree. It's time to get rid of fluid restriction. I don't think it helps. If anything, patients are miserable. They're thirsty. They're peeing 100 millimoles of sodium. That's a lot of fluid. It's the interstitium. Their interstitium is really there's a lot of shifting happening in the kidney. So I think that that will be the best thing to do to get rid of the fluid restriction. And as Dr. Eggman mentioned, there's already evidence of clinical trials not that it doesn't do anything more, no difference.
Thank you. So the last question in the Q&A pod comes from Dr. David Lin, who says, great talk. And does it make sense then to obtain blood volume analysis on most patients with CHF before discharge?
Most? Is it most? Or is it
Yes,
all?
he said most,
Okay.
yep.
Sure enough, so I didn't want to get in trouble with him. So I think blood volume analysis definitely has a role because as I said, there's a lot of disconnect between filling pressures and overall blood volume. I don't know, I don't have an answer on which patients they're good to get a blood volume, but definitely a role for a lot of patients because in part of what, like what we've been understanding and investigating is if there's a correlation or should we do a little trial here at MHI on correlating people that, because at some point the urinary sodium gets low, and then do we correlate that low urinary sodium in a blood volume analysis? That might be a nice little project. But I think that definitely there's a role for some patients to get blood volume before discharge. The hard question is when to get it. So. Other questions? Well, thank you so much for being here and